topic is VMS management, what is new? And I would like the Estella Group to have sponsored this session. And we are looking forward because right now we don't have the molecule in India, but we hope in the near future we are going to have this wonderful molecule. The unmet need where MHD cannot be given, we have an alternative. So that is the position of this particular molecule which is going to come in. And this is a primer for us to understand the molecule, because any new molecule which comes in, it takes some time for us to understand it. The confidence building, that we trust this molecule before we prescribe it to our patients. It's very, very important that we need to have trust in our prescription. So the trust doesn't come in just so easily, isn't it? And especially for that menopausal women, because you're worried about all the adverse effects any molecule can happen. So it takes time for us to go through the literature, to see what's happening, and what is the evidence saying, and what is there. So this is kind of a primer for that. And so the way we are going to have this, so I can be a little relaxed now, because we're going to have the discussion after the oration. So that 15 minutes thing is a little more relaxed for me. So we're going to have, going through this, what is the rationale? Why should we be treating the vasomotor symptoms? Is there really a need to treat vasomotor symptoms? There are a lot of people who can manage vasomotor symptoms without any treatment. And they just go on suffering and nothing happens. And then finally it goes off after 1 year, 2 years, 3 years. So what is the rationale for treating this vasomotor symptoms is one. Second is, what is the Nilam, please come. So what is the pathophysiology of vasomotor symptoms? And we compare the hormonal and the non-hormonal, which are existing now, versus the new molecule, and what is the evidence for this new molecule in this entire treatment kitty of the menopausal symptoms. So the rationale is hot flushes exist, and it is the person who's undergone severe hot flushes can vouch that they are terrible. And people, as surgeons, sometimes you stop your surgery because you're sweating so badly. It's not just the sweat. You start having palpitation, and some people feel giddy. So these are real situations which the gynecologists face when they are, say, at crucial situations when they need all the attention. So it does affect the quality of life. And what all happens, we'll tell you. So the next is, what is the rationale? Like I said, quality of life. And for us, working people, quality of life is so, so, so important to deliver, to increase our work productivity. The work productivity is lost if we are not healthy. So that's where it stands. And then there is a lot of good information to say that when a woman suffers from severe vasomotor symptoms, probably it's a red flag for the future. If she's already genetic predisposed to a cardiovascular event, then perhaps this vasomotor symptoms, they have seen that people who suffer from vasomotor symptoms end up with having more cardiovascular problems in later life, more number of osteoporotic fractures or low bone mass in later life, more link to the GSM because estrogen deficiency over a period of time. So all that long-term problems can happen more to women who suffer from severe vasomotor symptoms. So that is the rationale. That is why a vasomotor symptom has to be looked into and not just waved off. So that's important. And then there is very interesting one paper which I came across which said that if you're treating with estrogen the vasomotor symptoms, these women have low estrogen levels, and finally the biological aging also is far better. So I had heard a lecture, I think most of you would have heard when the Lenzetto was launched in India by Peter, somebody I think from UK. I'm not able to recall the name. And he said they had a get-together of all their colleagues. He's probably 60s and 70s. So all the gynecologists who were on MHD looked far younger than the gynecologists who were not on MHD. So this is not evidence-based, it is personal experience. And he was laughing and saying, and this is a fact. So that's what it is. So it does affect, and of course, quality of life for us is important. We want to be like that old lady who's hoisting a flag. We want to be like that old lady who's busy, onto herself. So this is how we look forward to for our, as we age. The prevalence, yes, it is there in India. Earlier on we used to think vasomotor symptoms don't exist, it's only the body pains, but here, this is the Indian Menopause Society. There are 2 papers from the Indian Menopause Society. One was done in 2012 in the climacteric, and there you see it is a multicentric, 8 places in India, and we had the vasomotor symptoms almost 75%. And one was under Dr. Shobana and Sudha was also, most of us were also involved, but Shobana and Sudha had spearheaded this, and there also they found yes, vasomotor symptoms do exist. So vasomotor symptoms are there, and quality of life, we have these 2 papers, one by Sudha and one by, I think one by Kalhan and Yara. So 3 papers only in quality of life. And all of them show that menopausal symptoms affect quality of life, which needs to be addressed. Approximately 42 million Indian women suffer from moderate to severe symptoms, and this is going to increase exponentially. So that's a huge area, unmet need that we need to look after. But where do we stand? So awareness of menopause and hormone therapy in India, perspectives of HCPs as well as consumers. So this was recently published in Climacteric, and this was a population-based study where we, actually looked into the rural area, and then we took the feedback on what they think about hormones, what they think about the symptoms, and we found that because the doctors were almost 1,000 who responded, but most of them were from the IMS society. So they were well versed about the hormones. But when it came to prescription writing, they would prefer the alternative therapy than the MHT because the confidence building is not really as great as it should be today. So this was the outcome of the study. And so there was another study by Jamuna and the group over, and then what they did was, they did a very interesting way of doing it. They took the information from the young doctors, from the older doctors, and they tried to understand who's prescribing how much of therapy, what therapy. And what they found was something which is not very pleasant to hear, because the younger generation was prescribing to the tune of 84%, but when we asked, they said, yeah, we are not very confident about prescribing. Actually, we wouldn't know. So that is a dangerous situation. So we really need to be more serious about that. Now, many people feel that the vasomotor symptoms are just going to go off. It's not so. There are some people, it can go on lasting for years. So some of them may need therapy for 4 years, 5 years, and sometimes even 10 years. So now we move on a little bit to the basic neurobiology. So we know neurobiology at menopause is a big area of research, and it is so important because everything is finally linked to that hypothalamus and pituitary. So what is happening is when the estrogen is coming down, the FSH is rising, the LH is rising, and what is happening to the GnRH? So here you see all the happy hormones are coming down, and the sympathetic overlay is more versus the parasympathetic, isn't it? So that there is a sympathetic dominance which is not there earlier. So the sympathetic dominance, there is more of noradrenaline, and that is why the palpitation comes in. And that is why, all your happy hormones, the dopamine, the serotonin, all of them are falling. So your sleep is disrupted, your mood is off, your, all the other symptoms are happening at this particular point of time. Now, so you just go a little more in detail on this. So you see the hypothalamus, the pituitary gland over there. In the hypothalamus, the preoptic area, so there are 2 areas, the anterior and the medial part of the hypothalamus, which has got these particular neurons. One is the thermoregulatory center, one is the neuronal center, which is called the candy hormones that we call, that is the KNDY, pronounced as candy, that is the kisspeptin, the neurokinin B, and the dynorphin. So we are talking more about this because whatever medications are there, whether it is non-hormonal medications or whether it is the CBT, this hypnotherapy, everything is working at this level. So it's very important for us to understand a little bit of the basics. Only then we understand how it is working. Like I said, all the happy hormones go for a toss, and we have more of the noradrenaline playing over there. So all the therapies actually, get that balance in place. by the positive, whatever is happening at that receptor level. And this doesn't correlate with your blood levels of estrogen. It's the tissue levels of the estrogen which are very different from blood levels, and that is why your vasomotor symptoms, in studies they have shown, it never relates with your estrogen. The estrogens may be normal and somebody may be suffering from severe vasomotor symptoms. So there is a loss of feedback from the GnRH during this time. There is hyperactivity of this candy hormone. So what a very interesting study by this Rance and all, who first discovered this concept of this candy hormones, and they found that postmenopausal women who had autopsies, that particular neuronal area, there was a hypertrophy of those neurons, indicating they were overworking because of the lack of estrogen. So that became the basis for more research. So what happens is, there is a decline of ovarian estrogens, the GnRH is not in the pulses, it becomes more of a steady state. The pulses of the FSH and LH is also coming down. They are increasing over there. So at the hypothalamic level, the kisspeptin, the neurokinin, and the dynorphin, that is the candy neurons, they sense the decreased estrogen and they react to it by actually regulating the thermoregulatory zone, which is set at a particular pattern in the body, the thermoregulatory zone. So that is very important. As surgeons, we know how scared we are to have the TSH normal. The anesthetist doesn't like to operate if the TSH is high, because you know if you go into hypothermia, what's going to happen. So the body system, that thermoregulatory zone, your inner core body temperature is so well maintained. Anything goes wrong with it, there's going to be a problem. So that is what happens here at menopause. The thermoregulatory zone in the asymptomatic woman, the two blue lines, we have just depicted graphically. In an asymptomatic woman, the core body temperature is maintained at particular 0.05 degrees. But when there is a deficiency of estrogen, like you see in the symptomatic woman, the blue lines are close together. That means though the core body temperature is maintained, but then the estrogen not being there, the neurons are just giving a false alarm to the preoptic neurons, saying that the core body temperature is rising and you better do something to keep that in place. So that is exactly what is happening, and there are few women who react to it, and then this is at the neuronal level. So on to your right side, you're seeing the arcuate nucleus where the receptors, the estrogen deficiency is there at the receptor level. So this is at the receptor level picture of the neuron, and there you have the neurokinin B receptors which react and they send the message. You see the message is being sent through that white line, which is going to the preoptic area and the MNPO neuron, and then they react and they send the signals to the periphery. Ki andar ka body temperature is rising, you better vasodilate. You get that body temperature down, and that is why there is a flush, and then it becomes normal, and then sometimes people have a little bit of sweat. So that is how it is happening. So the neurokinin B inhibitors actually act at the receptor level over there, block it so that false alarm is cut off. And that is exactly what is happening probably with so many other non-hormonal therapies that we are dealing with. So these are the pictures to show that the blockage with the neurohormonal, and then this is what is happening. So this is again a very, very nice picture to understand what is happening for the core temperature. So the top one shows the temperature rise, that is the skin conductance, which has been done by some experiments, the skin temperature and the tympanic temperature. That is quite well maintained, whereas the skin temperature goes up. I don't think this will apply because 12 o'clock we are starting the oration. So I'm going to continue, and then we are going to have this session after that. So if it is 5 to 12, please let us know. Is it 5 to 12? 10 minutes, yeah. So we finish quickly in the next 10 minutes. So this is how the physiology of the hot flushes. So all the targeted therapies are designed based on this understanding. So the implications are, we have the NK3 receptors. So there are two, just like your alpha receptor, beta receptor for the estrogens, you also have those kind of receptors for the neurokinin. So each one of them will act in a different way. The NK1 actually helps also in the sleep and vasodilatation, prevents the vasodilatation over there. And so this is in a nutshell the non-hormonal therapies which are available, the SSRIs, the SNRIs, the fezolinetant, and all of them. And so out of all of them, the paroxetine and now the fezolinetant, 45 milligrams per day, is approved by the FDA. And it's there in so many European countries, and we are expecting it in the next couple of years in India. So, the post-WH, I think the non-hormonal became very, very important. And we have so many in the gamut, the SSRIs, the SNRIs, the gabapentins, the clonidine. Then we also have the duloxetine. Then we have so many isoflavones which flooded the market post-WHI. So all of them have dwindled because we realized that it was not value for money. Very few have stayed back. Very few, like your flaxseed or your estries or something like that. Apart from that, most of them we know don't work as good as the MHT. So there's always that gap and unmet need as to what to do when a woman really needs hormone therapy and we cannot give it. So these are the side effects of the SSRIs and SNRIs, and we don't feel comfortable prescribing the psychiatric therapies, isn't it? So fezolinetant, now this is a summary of all the guidelines. The Indian Menopause Society 2026 guidelines clearly says, and this is all based on one meta-analysis. So meta-analysis is like a mecca for the evidence base, isn't it? So all the guidelines have based their statement on this. In a meta-analysis, fezolinetant 45 milligrams once daily was statistically significantly more effective than other non-HTs in reducing the frequency and severity of moderate to severe VMS, and showed at least comparable or superior effects on symptom severity versus non-hormonal therapies. So this is a grade A recommendation. Similarly, the International Menopause Society 2025, they also had the same thing to say. Way back in 22 or 24, the NAMS guideline has put it as grade 1 along with the CBT. So everybody believes that it is a good molecule. So there was a little setback in between when people thought that it could probably have an effect on liver, but then we have good literature to say that the adverse effects on the liver is very, very minute, and you just need to be more careful with your monitoring. So there are a number of studies which have happened with fezolinetant. So they go by very interesting names. This is the Skylight. There are about 4 Skylights. So there is nothing, Skylight 3 is not there, but you have your Skylight 1, you have your Skylight 2, and you have your Skylight 4. Skylight 1 and Skylight 2 are almost similar. The entire thing, that is the postmenopausal women between 45 and 65, 40 and 65, the age group and everything is the same. Then Skylight 4 is an extension of the same for over a period of 52 weeks. That means long-term safety of this particular molecule is what you're looking at in Skylight 4. And so in Skylight 1 and 2, they have looked at 2 molecules, 2 dosages, 30 milligrams and 45 milligrams. And finally, they decided that 45 milligrams works better with the extensive studies. And so I'm not going to go too much into the details of the studies. But then what they found was the hepatic transaminase activity. It's never more than the, the danger signal, what we call the HYS score or something we call whenever you're looking at the adverse effects of a molecule on the liver. It always fell below that, below the T score. That means it's never beyond twice what it should be, and that is perfectly okay. So you stop it, and you be careful on people who have a liver problem. So to be on the safer side while we know more about the molecule, always do an LFT before you start the therapy. Do it after a month, or maybe after 3 months, 6 months, 9 months, you follow it up. Because till the molecule is in the market, post-marketing surveillance is also as equally important as the pre-marketing tests which have been done, because the real world evidence may say something different than what we would have done earlier. So efficacy studies have really showed that they work well, and first it was published in the Lancet, and second it was also published in the Journal of Clinical Endocrinology. So what it means to say is they have been published in very good journals, all these studies, and then they had some studies in the Asian countries. There was some moonlight studies. One Starlight is in Japan, Moonlight is in Asia and China, but in Moonlight 1, they showed that in the Asian women, it didn't have that much of an effect like it did in the Western people. So that is why they're coming out with more studies in the Asian countries, and that is why we should be having our own study in India before we can say how good it works for us, and that is what we're waiting for. So, but the safety is there, so it's very comfortable on that front. The Moonlight one also said that the safety is there, but the efficacy is not as much as it was seen in the Western population. So we have to work on that aspect. And now, so endometrial safety in the long term, it went on for 52 weeks, and the bone safety was also there. There was no change in the trabecular bone score, not on the bone mineral density as well. And the only probably mild side effect was a little headache, which is seen persistently in most of these trials. So that was the only thing that was there. So daylight is a special study. Now first they did the skylight. Now the daylight was, they chose women who were not, for whom the MHT was contraindicated, or the MHT was said this cannot be given, not complete contraindication or with caution, or those who started and stopped because of the side effects, or those who refused to take. So this was a special group of women. And what they found was, once they started them on the therapy, the efficacy started off immediately within the first few days, 1 week, and then stayed over a period of time compared to the placebo. So fezolinetant 45 milligrams, the indication is treatment of moderate to severe vasomotor symptoms associated with menopause. The newer drug, elizinitant, is also coming in, and I think that's been approved last November in US. So global regulatory authorities, all these places have the fezolinetant to be offered to the women, and we are looking forward for it in India. Thank you, Radha. Yep. So the summary is 60 to 80% of the menopausal women seek health. Onset typically at menopause transition. Novel NK3 receptor antagonist, fezolinetant and elenzinitant are the promising non-hormonal options for the treatment of moderate to severe vasomotor symptoms due to menopause. An excellent opportunity to initiate preventive, of course, health services in this women. So even if they don't have any symptoms, we would want them to get complete checkup done. It's not just vasomotor symptoms. They may be the red flags for something in future. Thank you so much for the patient hearing. So all my panelists, we are going to have the case discussion after the oration, so that that's also not interrupted. Thank you so much. Thank you, Estella, for giving us the opportunity.